Welcome, everyone, to our monthly patient education webinar. I'm Kathy Nickham, the Education Director of the DPC Education Center. A couple of things before we get started. I'd like you to know that your lines are muted throughout the program. You're welcome to put your questions or comments in the chat box. You'll see the icon for the chat in the upper right-hand corner of your screen. And our presenter will be answering questions as she goes along, so feel free to put them in during any slide that she's discussing. So I think we'll go ahead and get started. One last thought is you will see in the chat box, there is the SurveyMonkey survey at the end of the program that you can give your feedback to us. And Hannah will put it in again at the end of the chat box as we close, but it's also there at the beginning. So it is my pleasure today to welcome Dr. Elizabeth Taber-Hight, who is going to be speaking to us about high blood pressure. And we all know that it's important to learn what effects it can have, how we can learn to lower it, and she has quite a bit of insight to share with us today. She is both an internist and a nephrologist, and she practices at IU Health in Indianapolis and is on the faculty at Indiana University. Her father is also a nephrologist, and she grew up in a family involved in healthcare, so it is no surprise that her passion is caring for patients and working with people with kidney disease. Dr. Taber-Hight attended medical school at Touro University, Nevada in Henderson, Nevada, completed her residency at St. Vincent Hospital in Indianapolis, and did her nephrology fellowship at Indiana University, where she is currently employed. And one of the things you'll see on this slide is that some of the things she enjoys, and I just can't quite get beyond my question of asking Beth, what is your favorite roller coaster? I see that you like riding new roller coasters. So, and in my thought, riding a roller coaster could get my blood pressure up. So could I start with that question? And at this point, I'll turn it over to you.
Sure. Yes, thank you for the lovely introduction. Yes, I'm a born and raised Hoosier. So I will say one of the reasons I included the roller coasters is my family is a frequenters of Disney. We're kind of Disney nerds, and we recently got back from a trip with my boys, and they have a new roller coaster at Epcot that's a Guardians of the Galaxy, and both of my kids were ready to ride it again the minute we got off. They absolutely loved it. So they're big thrill junkies like me when it comes to roller coasters. I'm not going to be base jumping anytime soon or rock climbing, but roller coasters I will do. So okay, well, if you want to go ahead to the next slide, we can kind of get started with some of these things. So as we said, like I said, I'm a nephrologist at IU. I'm a little bit of one of the newer faculty, but I have loved it here at IU. It's a great place to train, great place to be. And this is something, hypertension, which is kind of near and dear to my heart. I think there's always the misconception that it's cardiologists who manage high blood pressure. And while they do, nephrologists do a lot of this too, because the kidney is really responsible for a lot of the physiologic mechanisms that kind of control our blood pressure and take care of us as people, so that we can get up and move around and our heart can pump, with everything that we would want to do. So I wanted to go through a couple things about why, what do we call high blood pressure? What are the actual definitions? So that when your physician says you have high blood pressure, what does that mean? And what do those numbers mean? There's many numbers that go into blood pressure. What does it mean? The top number, the bottom number, all that. I'm going to take some time to go through with you guys a little bit on medications. I frequently, when I talk to my patients about medications, they know maybe the names and the dosages, but what kind of medication, what is it indicated for? That is sometimes something that we as physicians don't do the best job of telling you guys. And while I don't want this to be a pharmacology lecture, I figured it would be nice to maybe touch on those things and give you guys a little bit of maybe a little more understanding on that. And then kind of towards the end, I wanted to go over some stuff that you can do at home, things that you can try to help improve your blood pressure that are more than just what the pills that we throw at you. And then lastly, a little bit on what to ask your doctor, a little bit on labs, stuff like that. If you can go to the next slide, please. So what is that definition of high blood pressure? So there's many different associations that help us define blood pressure. And one that I usually kind of go with is the American Heart Association definition, which is high blood pressure or hypertension, as it's called in the medical world, is defined as at or above 130/80. So that 130, that's the systolic, the top number. And what the systolic pressure is measuring is actually the pressure when your heart is pushing blood forward. So your heart does that whole relax and then push, relax and push. And when it's relaxing, it's allowing the heart to fill with blood and get all of that good blood in there from the lungs and from the rest of the body, and then pushing it forward to where it's destined to be, whether that be back to the lungs to get oxygenated or to the rest of your body to deliver that oxygen so your muscles can move. So that top number is bigger because it's that push forward, it's that collapsing of the heart. And then the bottom number is the diastolic blood pressure, which is the pressure when your heart is actually relaxing to fill. It is more important in adults that we control your systolic, that top number. That's the one we care about most. While the diastolic isn't unimportant, it tends to be more indicative of blood pressure issues in children. About 47%, sorry, of adults in the US have high blood pressure. So that's a lot. That's a lot of people in the US who have high blood pressure, and 1 in 4 actually have it under control. So a lot of people have it, and not a lot of people do a great job of getting it under control. And it's more common in men and women. Some people may have kind of experienced that, where they tend to see more men that have high blood pressure than women, although women can still get high blood pressure and heart disease. Next slide, please. So this slide, since we've got people from all over, I wanted to look a little bit, and this is from the CDC actually, and it's looking at the prevalence of high blood pressure in adults age 20 or older. This is a little older of a slide, it was 2017, but it was a self-reporting poll. So have you been told by any medical professional that you have high blood pressure? Interestingly, it tends to be more of the southern states that tend to have a little bit more. These are also areas of the country where we have, a lot of people. Southern, maybe a little bit in the Midwest, but just as to give you an idea where the more prevalent population of high blood pressure is located. Next slide, please. So what are the symptoms of high blood pressure? And some of you guys might have it and say, honestly, doc, I feel okay, even if my blood pressure is up a little bit. And unless I check it, I really don't know. So we consider it almost a silent disease. And that's one reason that it's really important as patients to look at our blood pressure and check it at home and monitor it. Because in the office, it might be one thing. At home, it can be something completely different. If your blood pressure were to get uncontrolled, be very, very high, that's where we get concerned about things like strokes and heart disease or even heart attacks. And these usually are not asymptomatic or without symptoms. People will start experiencing headaches. Occasionally, people will get vision changes. We can have patients who will come in with super high blood pressure and they have chest pain or they feel really nauseated. Occasionally they'll have more confusion. So family members will bring them in for confusion and they'll have extraordinarily high blood pressures. And that can be triggered by more than just not taking your medications. Maybe you're severely ill, something else is going on. Maybe you took something that could raise your blood pressure. But usually, even if blood pressure is not necessarily at goal, we can still, you can have high blood pressure with no symptoms at all. But when you start having these kinds of big symptoms, headaches, vision changes, all of these listed, that's when we get kind of concerned that we need to monitor your blood pressure a little closer. Next slide, please. So how should I be measuring my blood pressure? This is always a question I get from my patients. There is a standardized way of measuring blood pressure. When you come home and you decide it's time for me to measure my blood pressure, it's the morning, I'm going to do it. You actually have to sit for 5 to 10 minutes, feet flat on the floor, clearing your mind, not doing anything on your phone or talking to anybody. Your arm should be at chest height, so kind of resting on a table where you have your cuff. We don't want it in your lap or above your head. We want you to get a cuff that works. Wrist cuffs are known to be fairly unreliable. So those ones you slap on your wrist, they don't work very well. They don't inflate very well. So we always recommend an upper arm cuff, one that goes around kind of your bicep area. And you want to take any sort of heavy shirts or jackets off before you put the cuff on. Cuffs do eventually kind of wear out, so you want to make sure that it's within a couple of years of buying it. If you're concerned that your blood pressure in the clinic and your blood pressure at home are quite different, bring it into clinic and have your doctor or nurse check it against their clinic cuff just to see if it's still working. Like I said, sit for 5 to 10 minutes, feet flat on the floor, sitting up in a chair, arm at chest level, and then check your blood pressure. That 5 to 10 minutes kind of lets you settle in, gets rid of any kind of the jitters. And after that, that's a pretty reliable blood pressure if you've sat there for a little bit. And then obviously we want you to keep a log. So either a piece of paper and pen that you've got handy, or a lot of machines these days will keep an automated log for you. And you can just bring your machine with you to your doctor's office so we can take a peek and kind of know where things are at with everything. Next slide, please. So this is just a nice little diagram of that. So again, before you do it, no food or drink. 30 minutes, sit down. They say empty your bladder because they don't want you getting up while you have to try to take your blood pressure. No talking, arm resting at that chest height. This gentleman's got kind of everything going for him there. He's got his arm at the chest height. He's sitting back in his chair. He looks quite comfortable. That cuff is against his skin with nothing between it. His back is supported. So that's how we want you to look when you're taking your blood pressure. That's the most appropriate way. Next slide, please. So why should I even care? So, as I said, your blood pressure can be high and you feel perfectly fine. So why is it that we should really worry about trying to get your blood pressure at goal? It's not those crazy high numbers, 200, over 100, or you're having symptoms. Uncontrolled high blood pressure still has implications. So one of them being that it can damage your heart over time. It can cause heart failure. Essentially, your heart is pumping so hard and so much pressure, it can actually cause your heart to eventually fail. There's some debate about heart attacks. So you can have occlusions of blood vessels that feed the heart and cause a heart attack. In my line of work, you have chronic kidney disease. So uncontrolled high blood pressure beats up those kidneys a lot and can cause you to develop chronic kidney disease. It's the second most common cause of chronic kidney disease in the US. So we do want to make sure we keep that blood pressure under control to protect those beans. Stroke. So patients can have strokes when their blood pressure is too high. And that can really, have a lot of lifelong implications as far as neurologic damage. And then irregular heartbeat. So something patients have commonly heard of, it's called AFib, which is an irregular heartbeat. That can happen too as well with uncontrolled high blood pressure. Next slide, please. Okay, so there are many different types of blood pressure, different kind of medications that we use to control blood pressure. And I kind of, like I said, I wanted to go through some of these. So different medications are going to be used for different patients. And most of that is research-based. So we find that different populations of people, either based on their gender, their age, their race, their underlying medical conditions, certain medications can help with certain different types of risk factors. So your drug regimen may not be the same as your siblings or your neighbors based on where you are in your life and what medical conditions you have. So the classes that I'm going to go over kind of quickly are diuretics, what's called RAS blockade, which is your ACEs and ARBs, calcium channel blockers, beta blockers, and alpha blockers. So these are all classes of drugs. Next slide, please. So the first one is one that's pretty commonly used in kidney disease and heart failure and high blood pressure, which are the diuretics or the water pills. So we'll usually ask, are you on a water pill? Have you been on a water pill recently? The most common types are the ones that I've kind of listed here. Most people have heard of what's called Lasix or furosemide. It's a type of water pill that we use. It's a very good diuretic. It really helps get fluid off of patients and kind of dries you out. So that might be one that you've heard of. the biggest risk with it is that it can actually lower your potassium down. So it can cause you to lose potassium, and you'll notice that you might be asked to eat more potassium or even given a potassium supplement. And you can almost overdo it sometimes with these medications. So we can get people to be essentially too dry, and we have to give them fluid back. So they're very potent diuretics. Thiazide, this one is usually, the more common one is HCTZ, which is listed there, hydrochlorothiazide, or chlorthalidone. These are another type of water pill. They work in a different way than the loop diuretics and those Lasix, but they also are good for kind of getting some fluid off. These are also considered first line for blood pressure management. So we use a lot of thiazide diuretics to control blood pressure. And usually people tolerate them pretty darn well. They don't cause a lot of going to the bathroom the way that loops do. Loops make you have to pee a lot, whereas the thiazides maybe not as much. The biggest thing we have to watch for is that in a subset of patients, it can lower their sodium. So we have to watch those sodiums closely. And the last one is potassium sparing diuretics. These are used a lot for heart failure. So the one we kind of see most often is called spironolactone. Eplerenone is the other one. So they've got that "one" on the end. And these ones, as kind of the name implies, they keep potassium in the body. So as opposed to those loops that I talked about first, it can actually make your potassium go high. And like I said, I mean, all of these are being used as a diuretic, so they're trying to dry you out. So you want to be a little careful about taking diuretics, either when it's really hot out or you have an ongoing illness that's causing it, so that you can't maybe drink as much, like diarrhea or vomiting. These water pills, while I'm not saying don't take them, definitely something that if you are having some of those GI symptoms, may be worth talking to your physician to make sure that you should be taking your blood pressure pills, especially your water pills. I want to stop because since we are going through some of the pharmacology, does anyone have any questions at this point in time? Okay, well, the next slide, please. Okay, so next up is the RAS blockade. So the RAS is a system of hormones that's in the kidneys. It's the renin, aldosterone, angiotensin axis, and it involves the kidneys. It's very technical, don't need to know it. What I really wanted to emphasize to you guys is that this is a different class of drug, and that these drugs share a very common ending on their medication name. So when you see it, you can kind of have an idea. So one is called the ACE inhibitors, and these all end with pril. So it's lisinopril, ramipril, enalapril, benazepril. So they all have that pril at the end. So if you hear pril, that means it's an ACE inhibitor. These are really good blood pressure meds. They're one of the best, pretty well tolerated. They're really good for diabetics and for people with heart disease. So we love these drugs, especially in the kidney world. Biggest thing is, one, they can kind of raise your potassium and even your creatinine to some extent. Those kidney numbers will actually raise. Occasionally, people will get a dry cough with this medication. So if you start one of these and all of a sudden you have a cough, it's new. It's something to talk about with your physician. They need a little bit of lab monitoring, and they can't be taken by pregnant women. So if there's any women, young women, or you have a family member with high blood pressure that's considering pregnancy, this is a class of medication that they can't take. Very, very rarely do these cause some swelling of the throat. If that were to happen, you should stop the drug. This is one of those things that we usually go over this with our patients when we start any of these medications, but it can happen. You should always go to the ER if you ever have symptoms like that, but that's probably the one thing I let my patients know. And then the last one is the cousin drug to this is called the ARBs, and this is losartan, valsartan, olmesartan, irbesartan. So they all end in artan or sartan. And essentially, they have the same risks as the ACE inhibitors, because like I said, they're cousin drugs. Big thing is that the ARBs tend to have less cough, so sometimes they're better for that. But these are, like I said, very good class of drugs. So like I said, the ACEs with that pril and the ARBs with that sartan. So if you hear those, that's kind of what we're talking about. Next slide, please. Okay, the calcium channel blockers. This is another really common one. So there's two classes. One that it does more for heart rate control, which is the diltiazem and the verapamil. So these are actually really good for heart rate control if you have AFib, a fast heart rate. So since they lower your heart rate, the risk would be that they make it too low. And then the other one is what are called the dihydrogen pyridine calcium channel blockers. Amlodipine is probably the most common one used for this. Also excellent for blood pressure control. And I consider this a set it and forget it medication. So amlodipine, felodipine, nifedipine, they all end in that pine. Because we don't have to do any lab monitoring. So you can give patients these medications, they do just fine. Biggest complaint I see is lower extremity swelling. So if you're on one of these and your ankles are swelling, it might be your medicine more than you got too much water on. Okay, stick with me. I've got 2 more, and then we're going to get into some other stuff that might be a little more up your guys' alley. So next slide, please. So beta blockers, again, another pretty common class of drugs. There's ones that are more cardioselective and ones that kind of hit all of the receptors throughout the body. So cardioselective means they're really good for heart rate and they're good for heart failure. And this is your atenolol, metoprolol, which is pretty commonly used, and bisoprolol. And the ones that kind of hit everything are the carvedilol and labetalol. And if you notice, they all end in lol. So that LOL means it's that heart rate medicine, it's that beta blocker. And again, because they're good for heart rate, they can make your heart rate go too low. Occasionally I see people who are on these medicines that feel a little more run down than usual. And it's probably because we were dampening their heart rate a little bit. So when they try to exercise or get up and move around, their heart rate's not going to go up the way it normally would off this medicine. And then occasionally people will have some constipation as well. So this is that lull medicine. Okay, and then next slide, please. And the last one I'm going to cover is the alpha blockers and the vasodilators. So this is just a different receptor that we have in our body, but doxazosin, terazosin, prazosin, these are alpha blockers. Again, they added that zosin. These ones are nice because they're once a day. So you get a little bit of not having to take that twice a day or 3 times a day medicine. And I usually dose these in the evening because they can cause some dizziness. In men, these are also really good because they can help with urinary stream. If they've got an enlarged prostate, these work really well for that. And then the vasodilators, most often you'll hear about hydralazine. This is usually one of those, I've got you on 3 or 4 meds and we're going to try something else because it is 3 times a day. You have to take it 3 times a day for the hydralazine. So it's one that I don't love to give because of how many times you have to take it. And then interestingly enough, minoxidil, which is on that list, is actually the active ingredient in Rogaine. So it can cause some hair growth when you take it. It's a good blood pressure med, but yeah, it's the active ingredient in Rogaine. Next slide, please. Does anyone have any questions that they want to put? Let me check my chat box here. Or anything that's come up that they want to ask about on some of those medications.
Hi, Beth. This is Yolanda from DPC. I have a few questions. I'll just do one.
Sure.
I don't know if anyone else has the question, but I've heard that once you're on any type of medication for blood control, blood pressure control, that you must remain on it. Is that true or false?
So I would say yes. It's one of those things, and there's a common misconception that when we get your blood pressure down and under control, so in that 120, 130 range on that top number, that you're cured of your blood pressure, high blood pressure. Unfortunately, that's not true. Once you're diagnosed with high blood pressure, you will always have high blood pressure. It's just a matter of how the medications work to control it. But I would agree that once you're on it, you want to stay on it. So it's not one of those things that your doctor gives you a 30-day supply of amlodipine and you fill it. And when you run out of 30 days, you stop it. We want you to continue the medicine until you see us. We want to know that the medication is working and we want to know that you feel good on it and you're not having any side effects. So this is where keeping that blood pressure log when we're working with getting that blood pressure under control is especially important. I usually advocate when I start a new medicine that my patients check their blood pressure at least a couple times a week and let me know if it's not improving, because I never want to leave somebody with a new medicine and no real follow-up or plan for follow-up. So we want to make sure that we're keeping an eye on you. It's working. It's not causing you to feel worse. All of the goals, while I give you all the risks, the goal is always to make sure that you feel better and that we're protecting you at and all of your organs as best we can. So hopefully that answers that.
Yes, thank you. Do you mind if I give you one more question?
Sure, go ahead.
Okay. For someone that does have hypertension and the medication is controlling the blood pressure level, how important is it for that patient to still maintain a healthy diet? So let's say the blood pressure is pretty good, the readings are pretty good because they're taking the medication, but the diet hasn't changed. What damage, if anything, could that cause?
So I always advocate for a healthy diet, and we'll get into some of the dietary things as well here in just a minute. But I do appreciate that question because, yeah, I mean, to some extent, could you just be on medicine and choose to do maybe some unhealthy lifestyle choices otherwise? Yes, but most people's blood pressure gets a little worse as we age. I have very few patients that are able to stay on one medication their whole life. So, doing some of those non-pharmacologic things like low salt diet and staying active and drinking fluids will help to kind of lessen the amount of time that you have that you need extra medications. We want to keep you healthy so you don't have to take extra meds. So I was always advocate for a healthy diet to try to reduce that. And occasionally, I do have patients who have high blood pressure and who lose some weight or change their diet, and they're able to just be monitored off medication. It's rare, and most of the time, those patients will eventually need medicine again, but they may be able to come down on some of their medication or come off of some of the meds, at least for a while, if they can make those healthy lifestyle choices. Any
Thank
other
you.
questions I can answer? Oh, you're welcome. No problem. Okay. Well, I threw this table in here. This is a very technical table, but it's just to kind of show you that how we kind of go through things. So we may start with a combination medication, which I did not go into combination medications, but we may start with one medicine and then add a second one. And we do have plans in our head as to why we're doing what we're doing. There's a little bit in here about, a patient who's post-stroke or an elderly patient or a patient with a heart failure may do better with a diuretic than or spironolactone than other sort of medications. So this just gives you an idea that there is an algorithmic way we do this. We don't just kind of grab meds willy-nilly. I will say I have favorites. I have ones that I think patients do well with or are better tolerated than others. I'm sure all physicians do. If you ask them, they all have their favorite antihypertensive. We're weird like that, but that's why we're in medicine. But it's worth just so you guys know, this is not just, we're not little potion masters deciding what to do. We do use evidence-based, and we pick stuff based on what's going to be best tailored to our patient. Next slide, please. So this is probably the part that you guys want to know about most. So while it's great to know about your meds, the even better thing to know is what can I do that doesn't involve me having to step into a clinic or a hospital. Some things I'll tell you can't change. Some of it is your genetics, and genetics are genetics, and can't change those, at least not yet. So that's something to know, that if you have a really high number of people in your family with high blood pressure, then you're probably, a little bit at risk of needing it. But there are some things you can do and reduce your blood pressure and reduce your risk of cardiovascular disease, heart disease. Number one, stop smoking. If you smoke, stop smoking. There's no known benefit to smoking. It doesn't help anything. It may relax you. There's other things you can do, like yoga, go for a walk. Find a way to relax that doesn't involve cigarettes. And this includes secondhand smoke. It doesn't do any good to be around smoke. And again, for your loved one's sake, it's always good to just quit smoking in general. So we have people who have issues because they've been around secondhand smoke their whole life. So if you can get away from people who smoke, please do. It's just not good for you. Losing weight, even a moderate loss of weight, even 10% will greatly reduce your risk of heart disease, and it will also help with lowering your blood pressure. And I'm going to go through a couple of these in a little bit more detail. Increase your physical activity. I am not advocating you go run a marathon or an Ironman. Don't have to do that. Getting up and taking a walk, taking your dog out, doing a program at the Y, going swimming, just doing a little extra physical activity. Even working in the yard is a little bit of physical activity that will get your heart pumping a little bit, raise your blood pressure, help a little bit with good cardiovascular health. Lowering your salt intake. We are going to go into depth on this one. Decreasing your alcohol consumption and getting adequate sleep. So usually that means about 7 to 8 hours a night, but making sure you're getting good sleep and it's restful sleep so that you can help lower that blood pressure. Next slide, please. So what factors put me at risk? So we already talked about family history. Like I said, genetic links. If you've got a lot of people in your family who have it, you should definitely be monitoring it too. It goes for your children. So if you have kids and you have high blood pressure, you should make sure they know that they're at risk too, and they should have that monitored and checked as they age. As I said, our blood pressure does increase as we age. 9 out of 10 Americans will develop high blood pressure in their lifetime. So something to keep an eye on. Women are almost as likely to develop high blood pressure as men, although it is more common in men. But we're right there, ladies. So it's not just because we're women, we're not going to get it. So we have to be watching out for it too. And then ethnicity does play a role. So people of Black or African American descent tend to develop high blood pressure more often than other groups. So that includes whites, Asians, and Hispanics. And they also tend to develop it at a younger age. So again, if you have a really strong family history, you want to check your kids early and often to make sure that they don't also develop high blood pressure. Next slide, please. So how much physical activity? I said physical activity, how much? So we can potentially lower your blood pressure anywhere from 2 to 8 points on that top number, which is a pretty good sizable difference. And these are kind of the definitions. These are hard, but American College of Sports Medicine recommends 5 to 7 days per week of aerobic exercise of at least 30 minutes a day, 2 to 3 days of resistance training, and 2 to 3 days of flexibility training. So aerobic is like getting up and running or something that's going to make your heart pound. Resistance training is lifting, doing a little resistance. Again, it doesn't have to be, I'm not expecting anybody to go do CrossFit and lift, 500 pounds or, look like the Hulk. Not necessary, but doing stuff where you do a little bit with a resistance band or even little light 5-pound weights, 2.5-pound weights. Doesn't have to be anything huge. It's good for your bones too, for osteoporosis, especially for us ladies. And then flexibility training, making sure you're doing some stretching, really working those muscles. And then always start by talking with one of your doctors about a new workout regimen because we want to start slow. Nobody is expecting you, like I said, to go be do an Ironman right off the bat. So take it easy, take it slow, but get out there and kind of do a little extra physical activity. How much alcohol? So we recommend alcohol consumption should be in moderation. This is 1 drink daily for women and up to 2 drinks daily for men. So moderate alcohol consumption, no more than moderate, is considered okay for high blood pressure. And then, as I said, for every 1 kilo, which is 2.2 pounds, for every 1 kilo of weight loss, you can actually improve your blood pressure by 1 whole point. I should say point, not points. Apparently I can't type, but 1 point. So that's pretty good. So 2.2 pounds. So if you lose, 10 pounds, you're going to lower your blood pressure by maybe about 5 points, which is pretty good, especially when you're right on that cusp of being controlled in that 120 to 130 range. Maybe you're 135. Well, you lose a couple pounds, you might come down into the range that your doctor wants you. Next slide, please. So what about my diet? So there are many different studies on diet, and we're going to get into the nitty gritty. And it looked like actually the next lecture that's being given, the next webinar is going to be on diet, which is great. I think it's great to follow this lecture with that. I usually tell my patients, the DASH diet is one that was studied in heart failure patients. And the gist of it is fresh is better than anything else. So the more that you can make at home, the more that you can make that's either fresh or frozen, the better off you're going to be. Staying away from stuff that's processed. It's that processed food that's so bad for us. And it's really kind of rampant in the US. But, staying away from deli meat, especially restaurant food, fast food, anything that comes in a box or a can or pre-made sauces are all really bad. So trying to get rid of some of those is definitely something that you can do to help get yourself in a healthier spot. And in general, that's going to be healthy for you, even beyond just high blood pressure. Next slide, please. So I told you to talk about salt because salt is probably the number one thing that any kidney doctor is going to recommend is a reduced salt diet. If you can reduce your salt consumption by 25%, you'll decrease your blood pressure by at least 2 to 3 points, at least. And the average American eats about 3,000 to 4,000 milligrams of sodium a day. For people with high blood pressure, the recommendation is actually 2 to 3 grams of sodium a day. So really reducing that intake. You essentially have to cut it in half. The Dietary Guidelines of Americans recommends 2,300 or 2,300, sorry, daily for those without hypertension, and 1,500 of those with hypertension, which is, that's really hard. To only have 1,500 milligrams of sodium a day is really hard. If you start looking at the boxes of food, you will realize that that's hard. So that's why I usually give my patients a little bit of a range, so 2,000 to 3,000 milligrams. And this is the most common thing I hear from my patients is, Doc, I don't use a salt shaker. I haven't used a salt shaker for a year, so how can my salt consumption be high? 75% of your salt consumption comes from the food before the food even gets to you. So this is the packaged stuff, restaurant food. So really only a subset of your salt consumption comes from you and the salt shaker. Most of it's already there. So that's why fresh food and even like flash frozen, so frozen vegetables, frozen fruits, are better than anything that's pre-seasoned, because that stuff that's already made is salted to keep it fresh. So really reducing that salt consumption will be good for you. It'll lengthen your life to reduce salt intake. So it's something to really try to achieve. Next slide, please. So just what we talked about, I'm kind of re-emphasizing what I just said. So number one, buying fresh or frozen vegetables or fruits. If you buy canned veggies, choose the no salt added can. Number two, choose the low salt or low sodium option. So this is especially helpful when it's hard to give up that chip craving. They do make lightly salted potato chips and no salt added pretzels, stuff like that. They have those options. Look for prepared meals with 600 milligrams of sodium per meal or less. So if you need to go grab that, a lean cuisine, or you need you got to do something quick tonight because you got baseball practice, try to find ones that are lower sodium that you can use. Meat substitutes, especially the plant-based, like the Impossible Burger, be careful with those, because while it's nice to be on a little bit lower protein diet for a kidney standpoint, they are usually heavily salted to make them taste better. So be careful with that. Try to buy fresh meats and avoid anything that's pre-seasoned. So smoked, if it's a smoked or cured or anything that's like processed like sausage, or, it's got pre-seasoning on it, it's rosemary seasoned or anything, they tend to have a lot of salt. And then try the Mrs. Dash. These things are great, and they make about, 100 different varieties of Mrs. Dash. They're all no salt added seasonings. So definitely something to try. Try to avoid the salt substitutes. They're usually in the salt aisle or spice aisle. They're usually potassium based. And if you have any history of kidney disease, potassium is definitely a no-no. So avoiding those salt substitutes if you can. And that's what it'll say. It'll say like salt substitute or salt alternative. Those are not good news. Next slide, please. So what you should talk about with your doctor? I've got a couple more slides. So what is your blood pressure currently? So you want to know what your doctor wants to know. What are your blood pressures running at home? What are your weights running at home? So take it several times a week at different times during the day. I usually say 3 times a week at least. So I say take it one day in the morning before you take your meds, take it one afternoon, and then take it in the evening, and bring it to me along with your weights so I can look and see how things are going. And then you want to discuss with your doctor, why am I taking what I'm taking? So what am I taking and why am I taking it? So you can ask, like, I'm on this amlodipine. Why am I on it? Is it just for blood pressure? Bring it with you and bring your medication list, or you can even bring the bottles if it's easier, so that we know exactly what you're taking. A lot of times with my patients, if there's a question of why we're not getting anywhere with their blood pressure, I will have them bring in the bottles and we go through it together, because 9 times out of 10, something's been documented wrong and we don't know exactly what you're taking. So I want to know exactly what you're taking and how you're taking it, so that we can really make sure we're controlling your blood pressure well. Next slide, please. So a little bit about labs. This is probably stuff you guys see quite commonly when your doctors, especially if you see a kidney doctor, grabs labs. So we check things like a metabolic panel, a lipid panel, CBC, and A1C. That metabolic panel, it comes in multiple different types of flavors. You'll hear BMP, CMP, renal function panel, all these kind of alphabet soup. But really what we're looking at is your kidney levels, your electrolytes, and what your blood sugars are doing. So it gives us a little snapshot of how you're doing there. Lipid panel is to check your cholesterol, both your good and bad, and your triglycerides. Your CBC is your complete blood count. That's checking to see if you're anemic, and then look at your other cell lines like your white blood cells and your platelets. And then that A1C is to check and see if you're a diabetic. We shoot for, anything over 6.5 indicates a pre-diabetic to diabetic range. So that's when we're doing any sort of screening blood work, that's what we'll check usually. So these are things that you can discuss with your doctor. What does my metabolic panel look like? Am I anemic? How are my lipids looking? That kind of stuff. So now you know a little bit of the jargon. Next slide, please. Kidney tests, and specifically because I'm a kidney doctor. So kidney tests, we look at a couple things. So we look at the creatinine. That's a muscle protein that's broken down and filtered out by your kidneys. So if your kidney works well, you pee out creatinine and the number's low. If they're not working well, it kind of builds up in your system. So high is bad, low is good. That BUN, it's called a blood urea nitrogen BUN. It's a marker of kidney toxins. So it's the stuff that your kidneys should be cleaning out of your blood when they're working. We look at it to decide whether or not you need dialysis or if you have kidney failure. So if this is ever a debate or you're concerned about this, feel free to definitely discuss this with your physician. And then lastly is the GFR. I think of this kind of as a kidney function percentage. It's typically, it's actually out of 120, but I like to think of it out of 100 and kind of put it into percentage for my patients. Usually what they'll say is when it's normal, it'll say it's greater than 90 or greater than 60, depending on the lab. Anything with a GFR less than 60 means that you're in that chronic kidney disease stage 3, and anything less than 30 is stage 4. So this is for staging. While the staging doesn't make that much of a difference in terms of management, it does to let you know kind of where you are. Where are my kidneys? How are things going? Are we getting better? Are we going to get worse? Am I close to dialysis? But these numbers do vary day to day, minute to minute. And if you ever have any concerns, again, it's best to talk to your doctor. But that just gives you a little breakdown of what we're looking at and a little bit of what it means. Next slide, please. So I think that's pretty much all I've got. I wanted to give you a little bit on kind of kidneys and then a lot on things you guys can do. So hopefully this was helpful. I wanted it to be kind of an overview of medications and things you guys can do. I mean, high blood pressure is very important. It's important to control. It's important to have a bit of an understanding. I always advocate, though, always feel free to ask your physician if you have any questions about it, and keep an eye on it. See how things are going for your own blood pressure. Does anyone have any questions?
Yeah, I have a question.
Go ahead.
Okay. My question's actually going to be about low blood pressure.
Mm-hmm.
Give you some brief background. I'm 80 years old. I'm on kidney dialysis, and I'm 6'4", and like 3 years ago, I weighed 275 pounds, taking 6 different blood pressure pills a day, 4 different medications. So anyway, I'm seeing a kidney doctor. I'm told, headed downhill. Okay, so about 3 years ago, put me on a renal diet, such as that, and actually lost about 50 pounds. And of course, my kidneys continue to fail. So I went on dialysis 15 months ago. And prior to going on dialysis, you go through the bad period, and I gained, another 25 or 30 pounds, mainly fluids.
Mm-hmm.
How this works. So, hey, but believe it or not, the first month I was on dialysis, I lost 60 pounds, apparently all fluid. So anyway, for approximately a year and more than a year, my weight has stayed 190, 195 pounds. Also, my need for blood pressure pills got down to 2 a day. And my medical care, including monitoring the blood pressure, which is important in dialysis, is transferred from my nephrologist that I had all these years to a nephrologist that worked for the dialysis center, who's whatever. But anyway, my with that background, about 3 months ago, my blood pressures during dialysis started getting low, and where the high number was below 100, which is their cutoff for turning the fluid removal part of the dialysis off. You know, blood pressure comes up. Tried this, happened almost every session. They tried, you know, different things, whatever. Off. And then after about a month, and this go back 2 months, gave me a pill to raise the blood pressure.
Mm-hmm.
It's working, little trial and error, you know, as to what strength to pill, you know, for a couple of weeks. But anyway, this keeps my blood pressure above 100. And, you know, they're okay if it's 102, but if it's 99, you know, they cut it off. So I understand, you know, there has to be some cutoff, but my blood pressure away from dialysis is generally good, but in order to, the 3 days a week I have dialysis, I do not take my morning blood pressure pill. And I was taking nifedipine, not pronouncing that right, nifedipine.
Mm-hmm. Nifedipine.
Yeah, that's better pronunciation.
That's okay. I've been doing it a bit.
So the Monday, Wednesday, and Friday, I don't take that. And actually, my blood pressure doesn't, you know, really get up. You know, maybe in an occasional low 140s. And then every night, you know, I take a 25 milligrams Corvididil. I'm not
Mm-hmm.
pronouncing that, but and as far as why the blood pressure gets low during dialysis, you know, it's just the only explanation I get is, well, it sometimes happens. And then I was told, in addition, you know, another time, well, happens to a lot of people on dialysis. And as you know, dialysis, besides taking all the toxins out, it takes all the good stuff out.
Yes.
I'm on these vitamins, and I take a supplement, 8-ounce fluid thing every day that has 42 different minerals and vitamins and stuff I never heard of, you know, before I went on dialysis. But I don't know, I'm concerned, you know, I'm concerned I get very little information or answers from the dialysis place. But do you have any comment?
Well, I will say, I think the short answer is I think it's a good thing to talk with your nephrologist about, although it sounds like it's a newer person for you. You know, that happens sometimes on dialysis, and that's kind of a whole other bag than I was doing kind of the probably 20,000 foot view of high blood pressure because I wanted to give you guys kind of the rundown. But yeah, I mean, that does happen on dialysis where people will have their blood pressures drop. And it does kind of take some finagling between medications and changing things up to make it so that your blood pressure can tolerate dialysis. There's a lot of different strategies, but sometimes it will happen over time as far as people's blood pressure going down. You are not the first, nor will you be the last dialysis patient that I've had that came in requiring several medications and did not require that later as they were on dialysis. I do advocate you keep to the healthy diet and keep taking the nutrients that you are, so you don't get, you know, weak and run down. I know dialysis is definitely not a fun situation. Nobody enjoys dialysis. I have yet to have a patient tell me they like coming to dialysis. But I think, you know, stick with it. And like I said, I would probably talk to your physician a little bit too, if it's concerning to you, causing you discomfort, just to make sure that they're treating you the way you need to be treated. Any other questions that I could answer? It looks like I've got one in the chat, and there it is. You finish up with the blood pressure of 110/60. When I stand up, my pressure drops to 90/40. So, again, I think that's something, and that's a good question. This is what's called orthostatic hypotension, when your blood pressure drops when you stand. One thing is that when we stand up, all of the blood in your body goes to your feet because it's gravity. And if your blood vessels, which is mostly your veins, are supposed to contract, and the muscles around them are supposed to contract to push the blood back up to your brain so you don't feel lightheaded or dizzy. So some amount of drop is normal. Even normal people will have a drop in their blood pressure. More than 20 points on that top number, a difference of more than 20 points, which it kind of sounds like what you're describing, is called orthostatic hypotension. It can happen at the end of dialysis because remember, we're fitting 48 hours of kidney function in 4 hours on dialysis. So we're really running your body hard. We're removing all the toxins. We're removing as much fluid as we can. So there is some changes that your body probably can't compensate for the way that we would like it to, just because we're putting so much kidney function into that short little time period. Again, it's something that I would make sure that they're monitoring you at dialysis. And if it's bothersome to you, discuss it with your either nurse practitioner or nephrologist to make sure we don't need to do things like adjusting your dry weight, taking a look at your medications, make sure, because there are some medicines like the doxazosin, the OSINs I talked about, those alpha blockers are known to cause this drop in the blood pressure when you stand. So might be a good thing to review those with your nephrologist and make sure that none of your medications may need to be changed. But always good to kind of bring it to their attention, especially if it's making you feel poorly. Any other questions I can answer for anyone?
This is Kathy. Thank you so much, Beth, for sharing all of this information. There's a lot to think about. For those of you on the webinar, feel free to look at the webinar again. The recording will be available online in about a week. So there's a lot of information there. Please feel free to also share it. It looks like there is one other question or from Kelly.
2.0, can doing PD or more frequent? Yes, that is true, Kelly. We do. Now, I will say that this is all, I should preface this. I do home dialysis. I am one of the home dialysis physicians at my institution. And there are not good studies that show that it helps. So I can't say that this is evidence-based, but we do know that probably with more frequent dialysis and with getting better clearance on a daily basis, there's less stress on your heart. And usually most of those patients do have better blood pressures and less of that issue of dropping blood pressure. So I do think, like I said, while not backed by any evidence, my experience is that my patients who do daily or almost daily dialysis tend to do a little bit better with their blood pressure control.
Good information. Thank you for that. I think we have one more slide here. At this point, we'd like to thank everyone for attending. We appreciate your sharing your time with us. Please complete the feedback form that is in the chat box. And we encourage you to join us July 28th for our next webinar, which will be on the renal diet, and we'll go more in depth on some of the things that were touched on today. And we encourage you to become a member of DPC and enjoy its benefits. The membership is free, so come to our website and check that out. Again, thank you all for attending, and Dr. Taber-Hight, thank you so much for the great presentation today.
Thank you. I appreciate the invitation.
Thank you, everyone. Have a great rest of the day. Bye.